I'd like to introduce Mark Skinner for our first talk. He is the president and CEO of the Institute for Policy Advancement in Washington, D.C. He's the principal investigator of the Patient-Reported Outcomes, Burdens, and Experiences, the PROBE study, and will be speaking to us today about PROBE data with a focus on mild hemophilia.
So, good afternoon. It's wonderful to be up here. I was thinking the last time I was at Niagara Falls, I was probably about 10 years old, and I understand that's not unique, and I'm not even sure we came over to the Canadian side of the border. So it was just awesome to look out the window as I drove in. I came into Buffalo this morning. So thanks for having me back. It's been quite a while since I've been to your meeting. I think it was back when I was WFH president was the last time that I was here. So I am, I'm sorry, let me make sure my timer starts. So Okay. So I'm very pleased to have a chance to talk with you about some PROBE data. Some of you have heard parts of what I'm going to present today on a webinar that was held earlier in the year, but I think it would be great to go through it again. And I'm increasingly convinced the more I learn about those living with non-severe hemophilia, that there is a significant amount of work that we have to do as a global community. I don't know that it was mentioned, I live with severe hemophilia, not mild or moderate, but my mother had mild hemophilia, so some of this actually rings true. Here are my conflicts. Most of this is research funding related to the PROBE study and related work from it. So I wanted to start just with a little bit about what I have learned about mild patients in Canada, and then we'll move into some of the PROBE data from both Canada and around the world. So we know from the Dynamo study, which included data from Canada along with the UK, Italy, Austria, and it reflected. One of the findings from this was the age of diagnosis and the age of first bleed. And so you can see in the gold, and gold will be your sort of marker throughout this presentation. Everything related to mild I've highlighted in gold for you to follow easily. But what we see here is the age of diagnosis was around the age of 5, the age of the first bleed around the age of 11, and the age of the first joint bleed around 13. So this is not exclusively Canadian data, but it gives you a sense of sort of the delay in recognition. So what's happening during this period when we don't know or later in life? So we also, in the Dynamo study, there was a study in conjunction with the International Prophylaxis Study Group where they looked at MRIs for a cohort within the study. So there were 51 individuals, again from the same population. There was a small group, about 32, so about half of them had mild hemophilia. And I think what's interesting here is even though we know that the bleed rates are reported to be low, the annual joint bleed rate, 0 within these 51 individuals, when we looked through the imaging, we can see that already there are soft tissue or osteochondrial damage changes, much like we've heard about in severe hemophilia, those microbleeds that have never really been overt clinical bleeds. So something's going on. Despite the low frequency of joint bleeds, there are things going on in the non-severe patients that merit recognition. So looking at the Canadian data specifically, so this is data from about a year ago from the Canadian Bleeding Disorder Registry. You probably are familiar with it, but this reports on the annual bleeding rate by severity, and so it confirms what the previous Dynamo study was reporting, that there is a low bleed rate, although this didn't reflect 0, and the mild population here out of the CBDR was about 1,400. So a robust data sample, and you can see how they compare with their cohorts. And so the 3 sets of bar graphs are the annual bleeding rate, the annual joint bleeding rate, and I should be able to look better. Spontaneous bleeding, thank you. I said I didn't bring my proper glasses for this. So one of the other things which has been a popular topic is intracranial hemorrhage. It's one of the leading causes of death in hemophilia generally now, but what do we know as we drill down into severity about intracranial hemorrhage? And so this is data from the INSIGHT study. So this does not include Canadian data. It was European and Australian data. But what I think is remarkable, and one of the findings from this is that the fatal intracranial bleeding was 3 to 5-fold more frequent in those with the mild population compared to the general population. So it reflects, I think, another importance of understanding the risks of mild. And that may be because they're undiagnosed, they're diagnosed late, they don't have the same level of education or training. I think there's a lot of variables that we could certainly tease out to why this is the case. So let's look at the PROBE study. And for those of you that aren't familiar with it, Canada has been one of our greatest partners, and certainly Shannon Jackson has been leading some work in helping us refine the instrument and the way we present data with her population in Vancouver. But the PROBE study is an international study. We're in about 105 countries now in a little over 50 languages. It's a 30-question questionnaire built in several parts that ask demographics, general health information that is also asked of our controls, so we can benchmark against it. Patients self-report their hemophilia and bleeding history, and then with permission of Euroqual, we include the EQ5D as the fourth element, so we can benchmark against a general public health instrument. So it is fully validated. All those papers have been published. I won't go into them, but the major domains that were identified by patients when this instrument was developed were pain, independence, education, employment, family life, and mobility. And so we developed these questions to provide a comprehensive sort of 360 view of what it means to live with hemophilia. So the first set of these slides is our global data. We published a paper, I guess about 1.5 years ago, and the title of the paper, Non-Severe Hemophilia, Is It Benign? And in the short headline, if you haven't already figured it out, is no. But let's talk about really what that means. So this is data from the full PROBE data set. We have over 10,000 individuals in the data set now, but this was our early slice of data. And so this is the 862 individuals out of the larger data set that had at the time reported mild or moderate hemophilia. And then we further looked at the males. I'll show you females on a separate slide in just a moment. And so the age here, as you can see, sort of across the controls, the mild and moderate are not exactly the same. The moderate's a little slightly younger population, and we have 102 mild patients in this data set. And so again, here you can see just in terms of characteristics, hemophilia A and hemophilia B, about what you would expect, and then those on the mild patients on prophylaxis and moderate probably is not far off from what you experience within your clinic, so a low utilization of prophylaxis compared. But interestingly, we're already seeing, as was reported in the global studies, joint problems that are being self-reported with reduced range of motion or other challenges. And so here, I think, is an interesting slide. So this supports the notion that there is bleeding going on. So here we see the mild patients that are reporting 0, 1, 2 to 3 bleeds, and the moderate patients. You could compare that against what you know about severe patients. But that, just even at the lowest end, that's only 83% that are reporting a low bleed rate. And probably this is unacceptable to us if you had severe hemophilia. If you're bleeding 3 times a year, you're not going to accept that. And certainly the mild patients, there's only 50% in that category. So you compare that to the prophylaxis data on the left side of the screen, and it begins to raise the question, what should we be doing about this? This doesn't make sense, and we probably wouldn't tolerate it for someone with severe hemophilia, knowing of the chronic and cumulative damage that comes with repeated bleeding. So one of the pain questions, or I should say, one of the sections of PROBE really drills into pain, and I think it's really one of the unique features about the PROBE instrument. These were questions that were developed in terms of definitions of chronic and acute pain by patients, in terms of how they think about it. Most pain is, what is your pain today? Maybe you use them like our center does, the little smiley faces or the brief pain inventory, and that's just reflecting sort of what it is when I show up to you. But what does it mean in my daily life? And that really really is what, when we focus group this over about 18 countries to develop these questions, it was, I can live with pain, but it keeps me from doing certain things. So we teased out, when is the pain occurring and how does it interfere with your daily life? So we identified 8 occurrences: walking, stair climbing, nighttime, resting, weight bearing, playing, and then other and things like related to a fall or trauma. But then we wanted to understand, just when it occurs may not tell you the whole story, but how is it interfering? So with my ability to really enjoy life, so activities, mood, walking, and even playing with your kids, being able to get down on the floor. How is the pain keeping you from doing the things that you want to do? So we looked here in this at the mild patient population. So the top line, reported acute pain, is 67%. Of those with mild hemophilia reported they had acute pain. Just about 59% reported they had chronic pain, which you would expect with sort of that ongoing pain. Acute pain is more closely defined with pain associated with bleeding events. It's a 12-month recall because this is designed to be an annual survey, so the rolling averages will be what will be most instructive. But then we look at the number of occurrences of those individuals, the number of times that it occurs, so of those 8 activities, or the number of activities within which it's actually interfering. And so these are aggregate totals that show you those trend lines. We actually have a poster coming up that was accepted for oral presentation at ISTH where we've actually taken this and done an intrapersonal comparison so we can track the same patients before and after. So this is aggregate data, but you can see here just based on the aggregates of these individuals at this snapshot in time when it was taken that individuals with mild hemophilia are reporting greater interference and occurrence of both chronic and acute pain, and it's more closely associated with moderate patients and not the healthy controls that are in our population. So activities of daily living, this is an ADL list that again was developed by patients based on sort of how they live their day. The questions are asked in order of basically how you live your day, from getting up out of bed, bending down to the floor, putting on your shoes, sort of dressing and everything to bed. We also included, because it was significantly reported as an interference, sexual intimacy, which has been reported in a separate paper, but that was one of the areas which really has not been studied well and discussed. And so there is a whole publication on that I won't go into. But here again, we see that the reported effect in the mild patient population, about 38% are reporting that one of these activities of daily living in the last 12 months was made difficult because of their living with hemophilia. And again, at the bottom, you can see the mean number of interferences. And here the mild is sort of midway between the controls and the moderates. So certainly I would not call this a benign interference of living with a mild condition. The last, I think it is the last area from this paper, was looking at the use of mobility aids. So this is everything from crutches and walkers, electric scooters, to orthotic shoes, an adapted car, anything that you are doing to really help your mobility gait or assist you in your daily living. And so here, the percentage of individuals that reported that they used one of those, maybe it's a brace or a compression for a short period of time. We do track the duration and the frequency of use in sub-questions, but about 46% reported at some point during the last 12 months that they required one of these devices to assist them in their daily living. Again, far in excess of what we're picking up in the control population. This is our female data, and I really put it all on one slide because I want to make sure that you know that we're not ignoring women. The data is still relatively thin, and we do allow women to self-report on how they diagnose because this is a global study. So they may have a formal diagnosis of mild hemophilia or moderate hemophilia, or they may be carriers and then go on to report that they are symptomatic. And so we lumped those two together and we sort of regroup them because we meet patients where they are, and so collect this data. So here we have about 42 women in our data set. And I think really the important thing here, the takeaway, is that they too are reporting higher acute and chronic pain than women with the control population. They're reporting greater interference with activities of daily living and greater use of mobility aids. But we really need to spend more time digging into this to see if it mirrors men or if just this sample size is inadequate to draw that conclusion. So we'll continue that work, but I certainly wanted you to know that this isn't exclusively men, which most of the data published to date is. So this is some Canadian data that was actually printed at the World Hemophilia Federation meeting last year. David Page, I haven't seen him yet. I've seen his wife. There he's right here in front. So David actually did this research and presented it in Canada. So we had about 555 individuals living with hemophilia and then 200 controls. So again, a nice control sample to actually look against. And so you look here, this is just general data at the time. So this is just a patient characteristic that of the 46, 14% of the mild patients, 43% of the moderates were on prophylaxis compared to the 88 that were of severes. So moving down then, going back through sort of similar metrics, again drilled in on Canada, the same data set, 24% of the mild patients in Canada were reporting use of mobility aids, 67% reporting a use of a pain medication. So this doesn't have to be a prescription or a narcotic. It could be anything from a holistic pain medication, it could be cannabis, it could be over-the-counter medications. They're taking something to control and manage pain, but we don't tease into the specific medication. So the same questions asked across all of them. And so relatively little difference in the milds. You know, the moderates may be that they too are undertreated, why they are reporting more pain medication, but we haven't looked at that specifically. And again, very similar when you look at the use of difficulty with activities of daily living. So the Canadian data appears to be very consistent with what we're seeing globally, which also then allows us some really nice opportunity for a deeper dive into some of the subpopulations. So one of the other things that we do look at in probe is employment or school status. And I will share with you some global data in just a moment. But what we were interested in understanding is what percentage of individuals with different severities, and is there a variation with mild hemophilia? If it isn't interfering with your work or school, then you would expect these numbers to be high. So the working full time was relatively similar, although slightly higher in the controls, probably not enough to be different. The missed days from school and work for the mild patients was higher, and that may be when something goes wrong with a mild patient, it really goes wrong, and that they are skewing the numbers. But nevertheless, I think it's important because it just sort of adds ammunition. And I think one of the important things is that people that are making decisions to retire early because of their health, their joints just might be wearing out. They're not able to work to 65 or 70, even though they're being untreated. So they're not having the same opportunity to be long-term and productive. And so just to give you an answer, because I shared before that we do collect the Euroqual data as well. So we have a benchmark that is internationally recognized, although probe is growing with some of the regulators and payers. And here we see that the difference in the probe scores. And while it doesn't appear that Euroqual is as sensitive for the more severe hemophilia, it does look like that we're seeing sort of a relatively similar trends and patterns. And so I put the prophylaxis data back up here because you see a diminished quality of life in mild patients similar to severe patients, yet only 14% of them are on prophylaxis. So again, if we want to move that quality of life up, maybe prophylaxis is one of those things that we should be having a deeper discussion. It may be because mild and moderate patients only come to the clinic once or every couple years, and they're just not followed as closely, so we're not picking up things that are going on internally. So this is a study out of Australia. So the Hemophilia Federation of Australia actually wanted to do a specific study looking at aging with hemophilia and what are the needs, sort of this unexpected longevity that we all are living with now, and what do we need to do to improve care and what the government and others are providing. So the bar charts on the right are a little faint, but let me walk you through them. So they specifically surveyed, this is men, with mild hemophilia greater than or equal to age 45. So this is just the subset of the data because they did get control data for those under 45. But here what this really does is highlights the problem between the control and the mild population. So the control and the hemophilia population. So the bottom graphic are the controls and the top are the individuals living without a bleeding disorder. And so we see again here looking at sort of now focusing on an age cohort versus gender, that 29% of men with mild hemophilia reported problems with mobility over the age of 45, 0 in the control pattern, 32 reported an ADL, 6 in the controls, 71 reported medication for pain versus 61, relatively close, and then the chronic pain much higher, which again you would think would be probably because of the joint damage. So again, aging with mild hemophilia, even though they may not have manifested with a lot of bleeding events, it appears something is going on, and they perhaps are suffering in ways that the centers could help them understand or address earlier. So I think some of the key takeaways, that we've learned, there was a supplement addressing mild and moderate hemophilia, and there was a paper that sort of summarized a series of work, including part of what I've already presented here today. And so some of the conclusions that we drew, and this was a U.S. Research group that published this paper, is that the lack of proper education and management for mild patients, or perhaps the lack of frequency of engagement with them, may be contributing to some of these poor outcomes, that maybe we need greater intensity in terms of outcomes, that the HTCs are, just sort of by nature of the way we've structured care delivery, less engaged with mild and moderates, although I've heard some anecdotally report during the COVID period they had the opportunity to engage more because it was all virtual, so maybe we've learned a few things to sort of shift this trend. Mild patients may not be as attuned to recognizing bleeding events, and they may not seek treatment, and so having data like this to help educate them about what might be going on and what it might lead to long term, I think is important. So the data seems to be clear and consistent to me, whether we look in the US, Canada, Australia, globally, that it is having a negative impact, mild hemophilia, on activities of daily living, and that there is absenteeism from work. And although I didn't include it in today's set of slides, there is an impact as it relates to sexual health and intimacy, and that was a separate publication. And I didn't think I had time, but I seem to be doing well. So sort of my conclusions in the red at the bottom are that we still have work to do. We need to do more understanding about women and certainly build out the data to see if it confirms what's going on with men or if it might be worse, particularly related to menorrhagia or other issues, maybe not the joint issues. And that maybe we need to think about what we're doing in clinics and how that is made available and what services, if any, we need to do differentially sort of across the lifespan, not just thinking of the young guys, but maybe preparing them for later in life, particularly if it means they're not going to have as long a productive work life. And so with that, I would be happy to take a few questions if there's time before we move into the next speaker. Or anybody who was an author on anything I quoted, if you want to stand up and correct me or add to it, feel free to do that as well.
Okay, thank you so much. That was a great review and so important. We do have time for questions if anyone has a question. We have 5 minutes, so I have a quick question maybe.
Sure.
While we're waiting for people to gather their thoughts. On the plane here, I was reading some of the papers, and I thought I read something about patients with mild or people with mild hemophilia having higher, like, other comorbid health conditions. Is that something you've come across? So I've actually not analyzed that. We do collect comorbidities in probes. So we have the typical comorbidity list that you would collect sort of in a clinic visit, and I have not looked. It would be easy enough to do differentially between sort of the different severities, but I think that would be... Well, I meant compared to general population.
Compared to the general population, yes, exactly. So out of our 10,000 surveys now that have been completed, I think probably about a third of them are controls, so it would be easy enough to benchmark that, or even conceivably benchmark, because for those, public health data would be available for us to get the general population estimates.
Interesting.
Thank you, Mark. Mild hemophilia is a big disease. I mean, the severe hemophilia is almost undetectable levels. Moderate has a very narrow range, 1 to 5%. But mild hemophilia comprises people with as low as 5% and as much as 39% or 40% factor 8 or factor 9. So what kind of, you're presenting it as if it's a single homogeneous entity, which clearly it isn't. Can you break that down a little bit for us?
Yeah, so we do collect the data in the same way that the WFH registry and others do when we follow the ISTH classification, so the mild, moderate, and severe. We don't ask individuals to report their specific factor percentage, so that is certainly a limitation of the data. I think one of the nice things is because Canada has integrated probe within the CBDR, where you would have the actual clinical factor level, that we could redo this analysis, particularly sort of building on the work that David did for the World Congress last year. We could drill in and actually see, where there are breaks, and maybe it is really, sort of that 5 to 15, which we, sort of talk about 15% thresholds. It seems that there probably are problems across the spectrum. And I'm not suggesting all mild patients should be on prophylaxis, but I am suggesting perhaps there's a little more education and work that we could do. Although, frankly, I don't know why everybody shouldn't have the opportunity to be normal and have normal coagulation, but I may be asking too much of the government too fast.
David?
Thanks for that, Mark. I'll just make an appeal to the group. You can see how rich this data is and how much Canada has collected. And so I'd appeal to, if you're on my CBDR, you'll get an annual invitation to complete the probe data. So please, if you get that, please do it, because it really teaches us a lot. And we actually use that data in health technology assessments submissions to CADIF and to INES. And if you have mild hemophilia, you probably won't get a prompt because you're not on prophylaxis, but it doesn't stop you from going to the probe site and registering and providing that data. So it's really helpful to everybody to do that.
Yeah. One of the things Shannon's actually been helping us do and piloting with the guys in her clinic is a new dashboard that'll be a patient dashboard they get at the end of the survey, where they'll actually be able to do some of this intra-comparison. They'll be able to compare themselves to others within Canada, with others with a similar severity, and be able to sort of pick and choose because we have a large data set. So we hope to roll that out before the end of the summer across the whole platform.
Pardon my ignorance, but probe, is there a pediatric component, or do parents, caregivers fill that out, or is it just for adults?
So it is on our to-do list. Probe has been demonstrated stable down to the age of 11. So everything has been sort of language scored to an 8th grade, and we sort of picked that time frame, which is roughly the age when people start to learn to self-infuse, go away, sort of self-manage. And so we typically, when we report, we use 11 as the cutoff. But we have thought about producing a version below that. It just hasn't made it on our work list yet. We're trying to decide, do we do a caregiver version? Do we do von Willebrand disease now and add it? And so it's, there's a long list, but noted. Thank you.